On behalf of the Department of Psychiatry and the broader UCSD community, I'd like to welcome you to this very special Grand Rounds. And I'd like to welcome back Dr. George Koob, who, as you know, is the director of the National Institute on Alcohol Abuse and Alcoholism, and who has been at the forefront of the neuroscience of addiction for many decades. And more importantly, has been a wonderful colleague and friend, both to members of the Department of Psychiatry here and the broader neuroscience community. So it's a pleasure to welcome him and to ask Professor Neil Swerdlow to do a more content-full introduction.
Thanks, Igor. Is this working? You guys hear? Great. Welcome, everybody, to our Grand Rounds. George Koob needs no introduction here. As I was standing with him before, everyone walked in the room was playing Who's Known George the Longest. George has been a friend and mentor to many of us here in the department. Indeed, he's the reason I came to San Diego in 1981 to study neurosciences. George is a director of the NIAAA for exactly 1 year today, I believe. He's an authority on alcoholism, drug addiction, and stress, and has contributed to our understanding of the neurocircuitry associated with the acute reinforcing effects of alcohol and drugs of abuse, and the neuroadaptations of the reward and stress circuits associated with the transition to dependence. Dr. Koob has published over 650 peer-reviewed papers and several books, including The Neurobiology of Addiction, a comprehensive treatise on emerging research in our field. Today, he'll speak to us about Neurobiology of Addiction, View from the Dark Side. Please join me in welcoming Dr. George Koob.
Okay, so which one?
That's forward.
All right. Yeah.
Okay.
Well, good morning, everyone. Whoa. Good morning, everyone, and it's a pleasure to be here in San Diego, and believe me, it really is a pleasure to be here in San Diego. All you had to do was watch CNN last night, and you know what I'm missing in Washington, and that was done on purpose. So, a couple of introductory things. One, I think I should mention that Neil was my first graduate student, and I'm very proud of that. And the other thing is, I was telling Larry Squire when we were sitting there chatting, and I spent the first half of my life basically trying to understand why we feel good, and I spent the second half of my life trying to understand why we feel bad. And today's lecture is the neurocircuitry of why we feel bad and how that came from learning about how we feel good. So that's where we're going today in simplistic terms. Just one pitch for NIH and the cost of addiction to society, and I like to show this slide. Of course, I don't show the bottom part when I'm at NIH. I show that only in the field, but I think it's pretty obvious that addiction to alcohol and drugs and tobacco cost an enormous amount to society. I like to tell people, if you go into any emergency room in San Diego County on a Friday or Saturday night, you're going to find that half the people there are for some kind of alcohol or drug-related problem. And I know that because my mom was elderly at one point. She's passed away now, but I spent a lot of time in the emergency rooms of San Diego County. But in proportion to the funding, there's an imbalance. And I also like to say, one last pitch, is that if we were able to effectively treat alcohol and drug and tobacco addiction, we could save quadrillions of dollars in healthcare costs. And I don't think that's ever filtered out to society in general. One poignant factoid, I'm now a repository of factoids, having spent a year at NIAAA, but one is that only about 10% of individuals with alcohol use disorders get any treatment whatsoever. And so this is a psychiatry department and program. I think it's important for us to realize that that's one of the huge challenges we face at NIAAA. How to get information on what's effective out there, how to get it to primary care physicians, and how to get primary care physicians to get it to the public. So it's a big issue that we're struggling with. We spent some time yesterday even talking about it. That's a sidelight. Now, what I want to really tell you about today has nothing to do with my work at NIAAA per se, other than NIAAA funded half of it for about 30 years. But I want to talk about a conceptual framework for addiction that weaves in the construct of the dark side. I want to talk about neuroplasticity in the brain stress system circuits. They involve CRF, corticotropin-releasing factor. I'm going to talk about some of our new work on neuroplasticity in the stress circuits that involve dynorphin, which may surprise you a little bit, but we're going to make an argument today that that is also part of the brain stress systems. And then I'm going to show you some very new data from Dr. Olivier George, who's now an assistant professor at the Scripps Research Institute, but still works with me and collaborates on some recent work showing that there may be interactions of the brain stress systems even with the reward system directly. And then finally, I'll just touch on the fact that the stress systems even impact the frontal cortex and executive control. And so if you haven't already figured it out, most of this lecture is going to be on stress and what I call the dark side. So what is the dark side? Well, I define addiction like everybody else, chronically relapsing disorder characterized by a compulsion to seek and take drug or stimulus, loss of control, and limiting intake. If I stop there, I don't think anyone in the room would have any problem with my definition. But I add on this part about the emergence of a negative emotional state, dysphoria, anxiety, irritability when access to the drug or stimulus is prevented. And I define this as the dark side of addiction. And I have a very This lecture goes from the sublime to the ridiculous, perhaps. The simple message, the framework that I work under and to study addiction work under this same framework. Salience disorder, but I'm also going to argue that it's a an executive function disorder. And these are, of course, it's still evolving, but I think of the addiction cycle. If stage refers to the basal ganglia, which is in blue, the bed nucleus is stria terminalis and the central nucleus. Green, or the preoccupation anticipation stage. Diagnostic criteria in DSM-5. And so our argument, this is a heuristic. Instructing patients on what went wrong with their brain to circuits we want to bring back into homeostasis. Involves a focal point in the nucleus. Roberts, when he was a postdoctoral fellow with us, rats stopped taking cocaine, all right? Turns out they psychostimulant drug. So we've known, this circuit encodes as defined by structures of and can contribute in a significant way stages to the binging that occurs when really cool hypotheses out there of how this plasticity takes process, if you will, evolve. question of plasticity, recurrent loops, that Susan Haber and Bill all contribute to this. But God Janus, which is two faces of this. The argument I'm going to make here is that and as many of you well know, stress and individuals as we're beginning to understand genetic loading. They look to the past. They often to indicate changes for. And so I'm going to argue that reward and stress and perpetuate addiction. And I've defined these. And that comes from Susan. More emphasis on the psychological, behavioral aspects of stress. You know, reward is any stimulus. So this is critical. I actually wrote this in a science paper, okay? I called it annotated boxes. But my argument has been hedonic Calvinism refers to the fact that at some point and that, of course, goes back to an old theory ago and involves the hedonic or negative hedonic Richard Solomon put in his paper to describe what happens in the A process, which is feeling really good. What Solomon further hypothesized is that the process gets bigger, and then later theorists, such as Francis parent tolerance, because the B process by a method of subtraction. So a hypothesis that has and I did an experiment where I had always thought, and I'm not going to go through the whole experiment, it was mediated by different structures than working at Scripps. She was part of an honors thesis with me. On to become a clinical psychologist. And we most sensitive site to elicit what I would call other than the reward system, but within the reward system. That it was the same systems that are. This is going to be the theme that goes through the rest of the talk. Psychology 101 construct that needs to be. I don't know what that is, but negative reinforcement is actually defined as the emotional state of drug withdrawal increases the probability over at the Crick conference room in psychology. Here in psychology, I don't have to define negative reinforcement. Everybody gets their knickers in a twist over this. Wants to avoid something aversive. And it's critical. All right, so speaking of such things, Tina Marku pioneered in my laboratory how can we measure in a rodent, how can we set up an animal negative emotional state, the B process? Med serendipitously came to my lab as a limited access to drug. They started to human drug addicted individual. And so let's take the left-hand panel up here. They are very, very stable. That way I have 1 hour access every day. They stay relatively. But if you let half of the rats have 6 escalation in intake, we see it. We see it with nicotine. I'll show you that later. Access. And I'll let you think about the implications of that. Paul Kenny and Athena and a herd of other rats and followed their brain reward thresholds during reward thresholds. That means a decrease in reward. You know, you could say, well, that's just tolerance. Of course it's tolerance. And it's not a word that people tolerance. So there is a compromised brain reward. And my argument is going to be that representation from there's been a change in the color of the nucleus accumbens. So nucleus accumbens has turned on us. But I'm going to argue and arousal and reactivity and emotional amygdala. And then, you know, in that there were 2 types of adaptations that could occur And we argued that maybe the same systems that code within system adaptation. So a simple version of that is compromised in human addicted individuals. To support that hypothesis, and I'm going to give you some examples of how I think that occurs. Between system neuroadaptation, some other system in the effects of the drug, of at a between system neuron. So what's the, so this heroes from San Diego and colleagues, and Catherine Riviere, Jean Riviere, Joachim Spiegel, that CRF controlled the pituitary adrenal response. CRF also controlled the sympathetic nervous system, which is illustrated. Contributed to behavioral responses to in the pioneering work on this. And an amygdala, they're in the right places. And in short, this peptide controls would occur, you'd be out of here like a shot, and you they had to trap it out not too long ago, right? Responses, you would see everything activated, probably of addiction, and I don't remember which postdoc themes, probably with Steve Heinrichs or Stephanie to that, those studies as well. Neil Swerdlow, we did. But in the end, we discovered microdialysis, and many of his colleagues extracellular levels of CRF in the amygdala all drugs of abuse during precipitated with that caused a great hoo-ha, which I won't go into. THC can elicit a withdrawal state that's in the central nucleus of the amygdala. Passions, which is trying to understand how alcohol produces. I was up at SRI last week, and I actually wonderful to see him again, but Joe Rogers was the person dependence in rodents. Getting the equivalent of about 1 or 2 glasses of wine in 30 glasses of wine, that's all they take in 30 minutes. Device, which is basically the rats live in these and this goes on for weeks. Elevator, and everybody was breathing alcohol out. Very dependent. And then if you this is critical that you understand this for the next couple of slides. Alcohol to reverse withdrawal. We actually used a liquid diet in those days. But we've come 4 to 6 glasses of wine in 30 minutes. (150 mg/cent) in 30 minutes. Very quiet, mellow rats. Attempt to reverse this compulsive. But here's the increased controls that are just social drinkers. CRF antagonist, this was the early peptide antagonist. Injection here in the central nucleus of the amygdala, you can see there is did this finding at least 12 times. We've and we've done it with micro injections in the is in the central nucleus of the amygdala. And I don't know fantastic reduction in only dependent. So there's plenty of data argue that CRF in the central you can reverse the anxiety. Dependence-induced drinking, I just showed you, with Yavin Jaham, abuse is reversed by CRF antagonists. Drug is not really altered. So it's really active. All medical doctors, I want to make a big point. And it also tells a story about a postdoc who was persistent. Corticoids have an inherent under high and chronic stress, which know there's a negative feedback of glucocorticoids to shut off paraventricular nucleus. But the piece that gets left out of all not shut off the amygdala, it sensitizes in the amygdala, it sensitizes CRF in the amygdala. That show these kind of data. This was the HPA axis, which is classic. In the amygdala. So I had a postdoc. This is correct, then we should be able to block the blocking the glucocorticoid receptor. And I said, something that occurs directly on the CRF neurons. A long-acting 486 that Etienne Beaulieu developed. The escalation. And so we came to hypothesize sensitization of CRF in the amygdala extra hypothalamic. And so one of the things and Dr. Leandro Vendrusco is how does status, we have a couple of hypotheses for why the PVN and so Leandro and I have some of these questions, but one of the things we think is going thalamic stress neurocircuit, but then later during protracted hypotheses that where they become sensitized. So applications, I think, for the treatment of alcohol. Neuroadaptations. I've told you about neuroadaptations. Well, this brings me to some of our, and as I told you, he was a postdoctoral fellow that Olivier hypothesized and Derek van der Kloy, yes, Neil, Derek. There was an action of CRF in the ventral tegmental area. I got to tell you about nicotine a little bit. Extensively, she led the way in my lab. I showed you earlier, but we've been chasing. This is a good example of where we've network, the turns led by Steve Tiffany decided to do a and, you know, after you hear about it, you'll say, well, that was. It occurred to me, maybe that's what we should do with the rats. Maybe instead. With gaps between every day. Did 2 days on, 2 days off, and what you can see is you let them have nicotine every day, they don't show the validity value of all this, but the fact is we've been able to so using that mechanisms involved in nicotine negative Changeurs group at Institut Pasteur paper in molecular psychiatry that came out last and we knew about some of this work ongoing. In the dopamine neurons with nicotine, you need to nicotinic receptors and the GABAergic up this burst responding. And that fits and so in the ventral tegmental area, and he decided to look at found is that in fact there is CRF as measured by PCR. You can see CRF mRNA, but also that there was in situ hybridization. He was tyrosine hydroxylase. TH also contains CRF, but occur, you can see here it's about 90%, but they manifest because he could knock down with a viral vector and he could reverse the withdrawal. And so the argument is in a sense the valence of the Pasteur showed that by activating selectively ability in the ventral tegmental area of the dopamine produce rewarding incentive salience-like effects, or it can be and this is a study Antonello Bonci and his colleagues at NIDA peduncular nucleus, pontine peduncular nucleus. And in VTA, you decrease in this slide, but putting I'm arguing is that suppressing the dopamine hypothetically what's been driving. But there's another, assuming I have time here, again, it's sometimes for, and it just, and that Bill Carl is on. It was driven by she's not with us anymore. But it was another which we can turn into a bit. But what they argued in this our talked about, or decided you trigger, one of which is the increase. You know that there's synaptic element. One of the things that trigger is an increase in the expression that they made and fed back and shut off the fact it was Tony the kappa agonist on dopamine. You can, and you may not know this because we agonists are aversive in rats and people. So, in this through other posts, Tim, and one of the questions, the kappa in this compulsive driven by the dark side. We did, but and this study is in neuroscience. A couple of extra experiments. These were rats on methamphetamine, and then with one dose morphine, which is a antagonist. And as far as I know, remarkable about it is it acts. I swear, a mouse or a rat with this dose of later, there is, and we don't know exactly transduction for this, but one thing we do know is Norbion. Kenner Rice showed me the. But anyway, these rats were treated. The controls escalate like normal, like escalation. Administration is measured with a progressive ratio. The site for this appears to be a small. The nucleus consistent with the Nestler hypothesis of Norbion into the nucleus accumbens gave us a very similar postdoctoral do this stuff with Norbion I. Went on to show that the escalation in alcohol piece of the puzzle. The other thing is that we know of the shell of the nucleus accumbens right here. A dramatic increase using these kind of measures. Immunohistochemistry animals. There's some in the short act in the and then nicotine model from a position now in Israel. Again, and Olivier George at the Norbion I, and they all. And so we're in site-specific mediated. So my second is another system that's widely represented again, notably the amygdala, is dinorphin. There are dinorphin peptide and drug addiction. We know that withdrawal-induced anxiety with CAP actually will facilitate state, but they and again, there's pretty good data out that CAP antagonists. So for me, this is a potentially effects reverse again this part of stress systems. That's not the only Amygdala. About CRF, I've told you, but there's also norepinephrine, vasopressin. I studied many, many years ago, genic-like, and there's even a stress-like orexin. And if this isn't enough to are organized transmitters. Treatment I've ever seen associated with a if you injected in small molecules that mimic the effects of neuroplasticity. One that's being studied Cacciopo in Italy, again, the activation of the. There are a number of investigators, some at NIH, with his work at NIH in our intramural program. So it's really intriguing. That I would mention the fact that we believe the whole of these is the impulsivity, particularly the ventral part of the basal ganglia. The ventral medial response in the amygdala. You will not only, but you'll have a sensitized stress system. That I hope to continue. PNAS just 2 years ago, again, a selective intermittent exposure to alcohol where the rat they're just binge administration or access model. It's not dependent rats, but what we in the prefrontal cortex, it's and between nucleus and amygdala. That the central nucleus of the amygdala, the cortex. So take out of line leads to but contribute possibly through activation of the stress system. Here's the simple version. Evolve. Use the reward system. And I really want to treat addiction. We need patient's development. The reward system is not good enough. the brain stress system to all these parts of the brain that I've been showed you that. You can rearrange the work, but the argument CRF and dynorphin play key roles in processes that we from Rob Malenka's work. In exposure to mental area, dopamine neurons that one exposure those dopamine neurons. CRF is part of the neuroadaptation. As you increasingly become nucleus accumbens, the ventral striatum in the is heavily involved in control that was ultimately you end up of addiction with system in the extended with the old while and I had some other people, but the idea was that there's an element in our persistence of addiction. And it's not so much to the normal state with continued insult. Claw their way back to a normal state. So they are using the wrong state. They're digging the hole deeper with every and an allostatic state that can ultimately lead an alcohol. So here's what I've told you. Drug addiction rewards. Compulsive drug taking produces an activation of CRF. It's a negative emotional state. Compulsive drug taking and to dysphoric-like responses in a negative emotional state. Just to negative emotional states. So brain identified through the study of opponent process disorders that are associated with dysregulated emotional that cast us insights into how emotions themselves a great number of wonderful postdoctoral fellows mentioned all the people in orange have jobs. Ami has a job. I need to move him out of there. Continuing as a postdoctoral fellow, and Carrie and Tim and Joel both at Scripps. On the glucocorticoid story, Leandro and Pietro Sanam. As you saw, much of the work on the orphan kappa story, Sun Mi Wee, Schlossberg and Ami Cohen. And I had in those thank you very much.
I mean, mind-blowing nuances of addiction. Frankly, out feeling bad is kind of a
Downer.
Would you be willing to entertain any questions? Or
Anything, even about NIH, if you want. I may not tell you the answer.
yeah, go ahead. So, contain.
Great. Wonderful talk. Thank you very much. Are infinitely available, or is there something special about
Some of you know I taught a course for 15 years that here. He helped me with, did the lectures on psychopath control. I must say, Reed is the master. Gambling, compulsive eating, compulsive drug stimuli. I think they can produce a phenotype as addictions, although they got close, I think, with internet. Of a gambler, a compulsive gambler, it looks a lot like an abilities in our brain, is my personal view, and this is not taking drugs, but drugs are a shortcut, okay? The animals are taken, it's tenfold higher than what right.
availability?
Yeah. But available. You know, the pathology, yeah, I would argue that. You can limit addiction. It's I have many friends like that who've both parents were alcoholics. Or epigenetic loading was they just never drank.
Just so Dr. Koob knows.
Phenomenon different before versus after puberty?
And the answer is you probably know already the work of Linda Spear, but there's pretty good adolescent animals, and the stress system comes on. Little evidence that I get asked almost every other all right, and I think some of the plasticity that you phenomenon, but there's other plasticity obviously that kicks in because but you know there's pretty good evidence that young rats are in behavior. and more. Pretty good evidence. Now, on that note, just to push some other institutes now have engaged in a image and do neurocognitive testing following their drug use and alcohol use and in a longitudinal study over 10 years. So because rats, I don't know whether you days 28 to 42, it's kind of tough.
Are there some other comments or questions? On brain development.
And that was the sort of degree to which this behaviors other than that are not associated with substance use. So actually emphasized is possibly behaviors in the context of gambling or
I think it's a gradation. You know, they look like cocaine withdrawal. Element of the dark side, and it sets up what I always used to tell lay audiences. They go to work and doesn't get the contract, and it's because they made contact and they're really, persona non grata, and then they get in their car and they start driving home and they pass and they can even see the lights inside the bar, and somehow magic to result in relapse. That raw nerve that becomes a manifestation. All right, so that's the way I look at it.
so this of dependence or might be particularly important for prevention.
Is that one slide I showed on the frontal cortex, and that in IAAA is that we are seeing some of you binge drinking in young people, and I might add middle-aged people. It's associated with alcohol poisonings over the last 10 years. Percentage-wise, but when they're drinking much more intensely. Compromised. because it doesn't fully develop. Period is this adolescent period for the ABCD study will be directed at, but it's an area this council will be reporting on 3 studies that this. Yeah. Sonia.
What do you think are the implications for comorbidity? Depression, anxiety.
Well, D is looming very strongly in our sights. Between the biology we know that 30% individuals with PTSD also overlap with anxiety disorders. You know, it's not is a key link with
Hi, I'm Scott Irwin, clinician at the From a clinical standpoint, I see a lot of patients that and now she clearly needs her Prozac, but she wants to stop because physiological dependences and psychological dependence and the doing all of those behaviors. But looking at your to these things, and I'm thinking particularly opiates, I'm wondering scientifically how you would think about this, but also how clinically.
okay, it really is, and it's not. How many physicians, many of them actually addicted to opiates, that they got and they were miserable for a day. It's okay, it'll go away, just, you know, wait. And in fact, I guess I would say that with so I have a very peculiar view of this, all right? With opiate medication, where when you go off of it, bring down. And at that point, you was or the chronic back injury or the it's just opiate withdrawal. But this is hyperalgesia. It's well documented in animals. I think that we have to reevaluate how we use opiate. Studies at Scripps Memorial. I mean, I know there are patients who their use when they start to the physician to say, well, maybe we should consider tapering of the drug. When the whole point to develop an addictive-like then the brain reacts. And a lot of the addiction. But it's one of my favorite topics, but I don't work in it very much. And
Psychiatry, UCSD, and the president of A New Path. I run a harm reduction psychotherapy group at involved in the community. The funding, as you stared your first funding to take his heroin vaccine to the difference between, say, cancer funding and drug and alcohol.
Fighting. You know, no. I really don't know how these things evolve. There are a number of proposals in Congress. I think there's one called if you feel strongly about these kinds of Republicans and Democrats come to an agreement. They all love NIH. Finding out where is the money going to come from. They all want to give us historically, I mean, cancer such good progress in it, and it's recognized dissolved, not completely, but largely dissolved. This or a pathology that it, you know, you just got to buck up. That they stopped smoking by themselves. They didn't. Before they finally stopped, but you know, so about the fact that there are brain changes associated with addiction. It's one of my charges to do, and I do it. You heard me. This one of these days. So, you know, I really think that we just need your way to this disorder and how much this cirrhosis of the liver, fetal alcohol syndrome, fetal alcohol. Even cancer, all alcohol. We all forget that.
Department of Psychiatry, Center for Behavior Studies, we show that of all the drugs made comparing with marijuana with the highest heritability. you have not touched upon genetic component. On this genetic heritability,
so I overlay vulnerability made the way low dopamine, high dynorphin, which may make using opiates for. I think the head around the genetics at NIAAA yet. It's something plans to do in the next month or two. Have come up as candidates. Some of them are kappa B, which is a hormones, and you know there are probably a number of other genes that have been saying, well, this gene is I'm not sure we'll ever get there. We might be able to gene circuits or gene pathways that influence. There's going to be some hope there. I think the other or a behavioral treatment is going to be therapeutic, and that would be there's a variant of the opiate receptor that particular sensitivity to naltrexone and makes that work better. Where they'll be able to identify we hope that that's going to be the case in addiction ultimately. That's who's vulnerable and who
well, we do have, oh, you have to get over here because I have a of making you, well, you don't need to be an on medicine, Department of Psychiatry, baseball hat. Now, I know anything, but
I think it's under $20, so I mean,
yeah.